Hello everyone, this is Shadi Reis from NCVH 2023 in New Orleans. I'm really privileged today to be with Dr. Ramzan.
Zakir, yeah.
Ramzan Zakir.
Yep.
One more time. Hello everyone, this is Shadi Reis from NCVH 2023. This is, one more time. It's the end of the day, so.
No problem.
Hello everyone, this is Shadi Reis from NCVH 2023 in New Orleans. I'm really privileged today to be with Dr. Ramzan Zakir to talk about medical management after CLI intervention. This is a very important topic, and I think this is a heavy interventional conference, but we always miss the part of what to do after the patient leave the cath lab.
Exactly. I mean, I think, a lot of the emphasis is on obtaining that optimal result, and I think we've gotten really good at doing that. And then I think it's afterwards we see that final result and we're like, okay, the patient's going to heal, my work is done.
Yes.
And I think we still have a lot of work to do after that successful intervention to improve outcomes.
Yeah, is this something for maintaining patency, but also or to prevent further disease?
So that's a great question. So obviously so these patients with CLI are very complex patients. So there's an interplay of multiple axes that are involved, right? So it's your LDL, and now we found that lipoprotein A. So little A also plays a big role with male, with the major adverse limb events, right? We have our diabetes to manage, we have our blood pressure to manage,
yes,
right? We have inflammatory markers, and obviously the cornerstone, is always, your bread and butter is your healthy diet, is your exercise, and obviously smoking cessation. And it's unfortunate that we still see, a lot of people after CLI interventions continue to smoke.
So Dr. Zakir, from your experience, what is the list of medication that the patient should be discharged on after successful CLI intervention?
Right. So that's a great question. So now we know it's not enough to just check that box that you put a patient on a statin. So I mean, we look at checkbox things that
for quality measures. And,
when we see for ACS patients, if the patient doesn't go home with the statin, what's going to happen. The whole hospital is going to come down on
flag
you.
of the day.
Right. In PAD, we don't really have that, but what we have to realize, it's not enough to just place a patient on a statin. LDL is a toxin, right? We need to drive that LDL to less than 55, even down to 30, and that's going to require multiple agents usually. So PCSK9 inhibitors, right? Have been shown to reduce male, post interventions and in patients with stable PAD.
Right.
So you're in the Fourier study, there was subgroup analysis of patients with PAD. So driving that LDL, further down as low as possible is going to improve our outcomes further down the line.
So in terms of antiplatelet versus anticoagulation, is there a role or difference?
Right. So that's a great question, right? So we know that aspirin has been the cornerstone of therapy, and then we kind of extracted from our coronary data that DAPT should be performed, should be utilized without great evidence, right? I mean, we know that it's, we have guidelines, for DAPT after coronary interventions and after ACS, but not so much the case, for PAD. And so really what's emerged is that it's not enough just to inhibit the platelets, that thrombin needs to be inhibited as well. Right, and so we've seen that early with Viraxapor, in the TRAP-TIMI study. However, that was associated with increased intracranial hemorrhage and kind of, it can be only used in a select group of patients, right? Now, the COMPASS study, which was a huge study, right, looked at low-dose rivaroxaban, 2.5 BID, with aspirin, and that showed significant reductions in MACE and MALE in that study, and that set the case for Voyager PAD, which looked at patients who had interventions and then, then randomized them to, aspirin plus placebo versus rivaroxaban. And in that study, we saw a lot of patients on DAPT, right? So, and we could extrapolate from there what to do, ideally post-intervention, right? So even patients who were on DAPT, right, they derived a significant benefit with the addition of rivaroxaban.
Absolutely.
But the key thing is at the expense of what? So we know that sweet spot in the first 30 days, there wasn't really an increased risk of bleeding. But as you move past the 30 days with the triple therapy, you did see an increased rate of bleeding. So perhaps maybe DAPT for that first month
It's
and
good.
then then
Beyond
maybe
that.
let go of the clopidogrel, and then have an antiplatelet agent and an
Yes.
thrombin agent. I think that now that we're seeing that to be a good long-term.
So kind of as you said, we're extrapolating from coronary data, like pioneer trial for triple therapy for coronaries.
Right.
But now we can do the same thing, just 30 days. Again, this is not guideline.
Not guideline based, but it seems to be
Practice-driven, yeah.
from the Voyager PAD we could extrapolate for that.
Yeah.
Yeah.
Well, to summarize then, lower the LDL regardless what takes as low as possible. It's not
Right.
about the giving the medication, about tracking the LDL goal.
Right.
And then antiplatelet, we spoke about an anticoagulation or
Antithrombin
vertebral
agents, yeah.
antithrombin agent.
Right.
Well, and controlling for sure diabetes, hypertension, and other risk factors,
Right. All
and
those
exercise and rehab.
things as well. Yeah.
Well, Zakir, thank you so much. That's very helpful.
My pleasure.
Yeah, shared your
Okay.
time. Watch these videos and others on NCVH YouTube channel. This is Shad Reis from Your Needs. Thank you so much.
Thank you.
Yeah.